Thank you for your kind introduction. It's my great honor to be here today. First, we will cover the diagnosis of alcohol use disorder, know your enemy. Next, we will focus on the management of alcohol use disorder, withdrawal syndrome, get compliance to ease the process. Finally, discover effective strategies for the management of alcohol use disorder, achieve abstinence, and regain control. When assessing alcohol intake, understanding the risks is key. The 2016 NIAAA guidelines classify risky drinking as 1 drink per day for women and 2 for men. Heavy drinking starts at 4 drinks for women and 5 for men. Remember, 1 drink equals 14 grams of alcohol. Screening for alcohol use disorder is vital. The Alcohol Use Disorders Identification Test audit helps classify drinking patterns. Scoring 0 to 9 points for men or 0 to 5 for women indicates normal drinking. Higher scores suggest hazardous or suspected alcohol use disorder. Early detection can make all the difference. Alcohol biomarkers provide critical insights into alcohol consumption. Non-oxidative metabolites like ethyl glucuronide and phosphatidylethanol ethanol are key indicators. They can be detected in urine, hair, or blood for varying periods. Accuracy depends on sensitivity and specificity, helping to confirm alcohol use even after days or weeks. Alcohol use disorder, AUD, is defined by the consequence of alcohol consumption, not by the amount consumed. According to DSM-5, it's the impact on daily life that matters in diagnosing AUD. The DSM-5 integrates the 2 DSM-4 disorders, alcohol abuse and alcohol dependence, into a single disorder called AUD. It further categorizes AUD into mild, moderate, and severe subtypes for more precise diagnosis. The strategy for alcohol cessation begins with acute treatment for recovery from alcohol withdrawal syndrome. This is followed by relapse prevention through medication and psychosocial treatment to ensure long-term abstinence. Alcohol withdrawal syndrome, AWS, is a major barrier to recovery in alcohol use disorder. It progresses through stages from initial symptoms like autonomic hyperactivity to severe complications such as delirium tremens. Early intervention is critical to manage these symptoms effectively. The CIWA-AR scale assesses the severity of alcohol withdrawal syndrome across 10 items, each rated from 0 to 7 points. Scores under 10 indicate mild withdrawal, while scores over 20 suggest severe withdrawal, potentially leading to seizures or delirium. Benzodiazepines are the standard treatment for alcohol withdrawal syndrome. As-needed dosing based on symptoms is the most effective approach. Lorazepam dosing varies with the CIWA-AR score, ensuring safe and tailored management. A frontline loaded approach using phenobarbital combined with benzodiazepines can significantly reduce ICU and hospital stays for patients with alcohol withdrawal syndrome. This strategy is particularly effective for those with or without a history of delirium tremens. When alcohol consumption is suddenly reduced or stopped, this imbalance leads to CNS hyperexcitation, causing withdrawal symptoms due to deficient GABA activity and excessive NMDA activity. The brief alcohol withdrawal scale, BAWS, helps assess withdrawal severity across 5 key items, symptoms, scoring each from 0 to 3. Treatment with lorazepam is guided by BAWS score with more frequent assessments and higher doses for severe cases. In severe or complicated alcohol withdrawal syndrome characterized by seizures or delirium, ICU care with high-dose sedatives, including anesthetic agents, is essential. Dexmedetomidine is a potent alpha-2 adrenergic agonist that can help manage symptoms and reduce ICU and hospital stay length. In cases of resistant severe alcohol withdrawal syndrome, propofol can be used as an adjunct treatment. A retrospective study shows propofol helps manage AWS effectively with comparable outcomes to benzodiazepine infusions, especially when standard treatments fail. Studies show propofol provides comparable outcomes to benzodiazepines, though it may lead to longer ICU stays and increased risks like hypotension and bradycardia. When managing alcohol use disorder, several relapse prevention medications are available, each with specific considerations for liver disease. Disulfiram is not recommended for liver disease due to its hepatic metabolism. Acamprosate is generally safe, but should be used cautiously in renal failure. Naltrexone is metabolized by liver and should be avoided in decompensated liver cirrhosis due to hepatotoxicity risks. Baclofen shows promise in liver disease, being both safe and effective. Topiramate should be avoided in hepatic encephalopathy, and gabapentin is useful when chronic pain is present, but hasn't been studied in liver diseases. Alcohol also affects the central nervous system by acting on GABA receptors. Acamprosate works as a modulator at these GABA receptors, helping to ease chronic withdrawal symptoms and reduce cravings. The combined study found that naltrexone, particularly when paired with behavioral interventions, is more effective in treating alcohol dependence than acamprosate. A systematic review and meta-analysis of 95 studies compared the effectiveness of acamprosate and naltrexone in treating alcohol use disorder. Acamprosate showed a moderate effect in preventing return to any drinking, with a number needed to treat NNT of 12. Naltrexone was also moderately effective, with an NNT of 20 for preventing any drinking, and an NNT of 12 for preventing return to heavy drinking. These findings suggest both medications are beneficial, but the choice may depend on the specific goals of treatment and patient characteristics. Naltrexone raises concerns about hepatotoxicity, especially in patients with chronic liver diseases. Studies show a significant increase in liver enzymes during treatment, particularly in those with liver dysfunction, highlighting the need for careful monitoring. Baclofen, a GABA-B receptor agonist, has shown effectiveness in managing alcohol abstinence in patients with liver cirrhosis. A randomized study demonstrated a significant reduction in both alcohol lapses and relapses compared to placebo, making it a promising option for these patients. Baclofen should be used cautiously in patients with cirrhosis or a history of hepatic encephalopathy and avoided in renal disease. Higher doses increase the risk of sedation and drowsiness, emphasizing the need for careful diagnosing, dosing, and monitoring. Topiramate, which decreases dopaminergic activity and increases GABA action, is effective in reducing alcohol cravings and heavy drinking. However, it can cause side effects like paresthesia, insomnia, and difficulty with concentration, requiring careful monitoring during treatment. So when choosing relapse prevention medications for alcohol use disorder, consider liver function. Disulfiram is contraindicated in liver disease, while naltrexone should be avoided in decompensated cirrhosis. Acamprosate and baclofen are safer options, with baclofen showing benefits in liver disease. Psychosocial treatment for alcohol use disorder includes screening, brief intervention, referral to treatment. Key therapies involve cognitive behavioral therapy, CBT, and motivational enhancement therapy, MET, providing structured support for recovery. Cognitive behavioral therapy, CBT, for alcohol use disorder aims to build skills to maintain abstinence. The program includes 8 core therapy skills, such as coping skills and problem solving, plus 4 additional sessions selected from 14 optional tasks for a total of 12 sessions. In CBT for alcohol use disorder, comparing the pros and cons of abstinence versus drinking helps the clients make informed decisions. Abstinence offers benefits like improved health and social skills, while drinking can lead to negative consequences like health issues and strained relationships. In CBT for alcohol use disorder, core beliefs like "I don't have a problem with alcohol" lead to autonomic thoughts and behaviors such as drinking. Identifying and challenging these beliefs and cues is key to breaking the cycle of alcohol dependence. Motivational enhancement therapy, MET, is a treatment approach that empowers patients to utilize their own resources for recovery. Rather than focusing on failures, MET emphasizes small successes and positive changes. It encourages patients to imagine the benefits of quitting alcohol and how their life will improve, fostering a sense of anticipation and motivation. This method respects the patient's autonomy, helping them develop a cooperative attitude towards their treatment journey. There are apps like MindShift CBT for managing anxiety and Rethinking Drinking for assessing alcohol use, which can complement CBT or MET strategies in alcohol cessation. Ladies and gentlemen, let me summarize my talk. Effective strategies for alcohol cessation, knowing as 6A approach, include ask about alcohol use and quantify intake, assess for alcohol use disorder using tools like the audit, manage alcohol withdrawal syndrome with medications such as benzodiazepines, phenobarbital, and anesthetic agents, and anti-craving agents like acamprosate, naltrexone, baclofen, and topiramate. Lastly, advise and assist through cognitive behavioral therapy, CBT, and motivational enhancement therapy, MET, to support long-term recovery. Thank you for your attention.